You get questions, you get...
Hi, everyone. We had an issue with the last video, and we are starting a new video, and we are hopefully going to go from wherever Elizabeth was, and I think she was down here, to breast issues. I'm going to start on her first slide, and we'll go from there.
Okay.
There you go.
All right. Hi, guys, again. Don't you just love technology? You're supposed to say, yes, we just love technology. Yay! Okay, so I am short. There we go. All right, so I'll start with this side. We talk about breast issues. Breast issues are very common things. Whoops, that's not what I meant to do. I meant to move that up in the corner. I need, yeah. Anyway, I got it too big. I don't know, how did I get it bigger? But that's okay.
Let's see if we can.
There we go. See, that's a touch screen. Yeah. Some of them are, some of them aren't. Okay. So breast pain is common, but severe breast pain and any lumps need to be fully evaluated. As I said earlier, some of these moms, if there's any family of breast cancer whatsoever, they freak out. So the girls freak out. Sometimes one breast will develop more than the other one as they're hitting puberty and they're breastfeeding. Sometimes they can be very painful and they hurt. Anything touching, it's kind of like when you're pregnant. If you've been pregnant and your breast hurt, if anybody touches them accidentally, these young adolescent girls, as they develop breasts, this can be very painful to them. Infants can also have engorged areolas. As I said, if it's saved in the other video at birth, and this is usually due to mom's hormone influence, and can even happen in the little boys, and so moms can get freaked out about it. Or if you notice it, bring it up in that visit and say, oh, they've got some breast engorgement, and this is just leftover hormone from you, and this should resolve all by itself. But then you need to make sure that you check it each time that they come in. Sometimes these can progress to a breast cyst that have to be excised. And if they're not gone by their first birthday, then you might need to send them to a ped surgeon to have that looked at and evaluated. I've had 2 patients, both in Eastern Kentucky, that had to have breast cysts excised. So who knows? Also, precocious puberty is something that always needs to be on your radar. Because you're not probably going to do the biggest workup on this. You're going to do some maybe, but precocious puberty will cause early breast development. And that's usually, if we talk about precocious puberty, that's usually before the age of 8. So if you've got, and it's not just, some of these overweight kids can look like they have breast tissue, but if you palpate it, it doesn't feel firm like a breast does. It just feels like fatty tissue. So you got to know the difference between an overweight child who looks like they may be developing breasts and somebody who's actually breast budding. So you got to be able to get your hands on them, and you got to feel. Gynecomastia is common in adolescent males, and certain medications can do that. Risperidone is notorious for that. And sometimes hormone issues, and sometimes even obesity. As we know, in older males, as the testosterone levels decrease and estrogen levels increase, that you see gynecomastia actually become more of an issue in older males. So gynecomastia in young males, adolescent males, needs to be evaluated. So. Oh, my papers are off. Okay. So as we all know, if you've ever had a period, guys, you haven't, but if you've ever dealt with women in your life who've had a period, lumps, masses, or pain that is not associated with a regular period cycle should be evaluated. And we all know that your breast can do funky things during your period. That's the reason you never want to do a self-breast exam during your menstrual cycle. You want to do it afterwards. So some of the things that you may do as a workup can be a pregnancy test, CBC, and an ultrasound if needed. I've had several girls who've had inflamed breast or knots or lumps that I could palpate. We send them for an ultrasound and then onto GYN if we need to. So far, nothing has had to. I've not had any adolescent females that have had early onset breast cancer. So we rarely do mammograms in adolescents, regardless of the issue if they are under 18, but that is not necessarily my call. I don't, because mammograms are painful, but usually you're going to ultrasound them first. And if a mammogram is ordered, that's usually ordered by a GYN provider. So think ultrasound first. So let's talk about amenorrhea. Primary amenorrhea is the absence of menarche by 16 with normal secondary sex characteristics. So if they've got the boobs and they've got the curves and everything else has happened like it's supposed to, but they've never started, then that's considered primary amenorrhea. And if by 14 they don't have any normal secondary sex characteristics and they haven't started, then you need to be doing some evaluation. I used to work with a nurse practitioner in Eastern Kentucky. His daughter had never started, and she had all the other secondary sex characteristics. And when they took her to the doctor and they did an ultrasound of her abdomen, they found that she was without a uterus, so, and ovaries. So she didn't have any male parts. She just didn't have any of the female parts, which is weird, that she had secondary sex characteristics, as you know, boobs in the whole 9 yards, without having a uterus well, she had ovaries. I'm sorry, I take that back, but she didn't have a uterus, so she couldn't have a period. So that was an interest. That's the only case I know of somebody without a uterus. But I've seen. But of course, you've got athletes. You have to kind of look at things. Your gymnasts who are so intensely training from the time that they're a young age, and they have so little body fat that a lot of times your premier athletes like that who start really early will have primary amenorrhea just from the amount of exercise that they do. So so you kind of look at all the issues and kind of see what's going on, get a good history. So sometimes it can be hormonal related, and genetic disorder that's pretty common that causes is Turner syndrome. And we've got a couple of patients in our practice with Turner syndrome, or mosaic Turner, which is a type of, you don't have the severe characteristics of Turner syndrome. If you don't know what Turner syndrome is, you need to look it up, because you may see it. Even if you're working in a what I call a family practice, you may see kids with Turner syndrome. So you need to know what that is. And then we talked about the anuterine situations that can be an issue. Okay, I mentioned in the other video with dysmenorrhea, things like menorrhagia and metorrhagia. So menorrhagia is normal intervals with excessive flow, and metorrhagia is irregular cycles with bleeding between. Menometorrhagia is excessive bleeding with irregular cycles. Sometimes adolescents, when you start evaluating their menses, their definition of excessive flow is not necessarily the definition of excessive flow. So you really need to evaluate how many pads, what size pads, how many days is it going on, does it start light and then ease off, those kinds of things. And you need to be able to look at some of these kids and say, that is normal period. With the pills so prevalent anymore, a lot of young ladies think it's like, oh, they just don't want to be bothered with the period. So it's easier to get on the pill where you can have 2 or 3 days of light flow and not have to worry about it and blah, blah, blah. So we have to be really careful with that. We really need to evaluate whether this is a true menorrhagia or metorrhagia, And we've got to rule out other pathology prior to that just being the issue. And it's like I said, it can be mild, moderate, or severe. And like I said, is usually treated with oral contraceptives, somewhere between 30 to 35 micrograms of monophasic with a potent progestin in it. But again, you need to be very careful. If you don't feel comfortable doing that, then you need to get them to a women's health specialist that knows what they're doing and feels comfortable doing that. So don't be afraid to know your limitations. Just because you're able to do a PAP doesn't necessarily mean that managing, periods with oral contraceptives is going to be your forte. Remember, you're responsible for everything that you prescribe. So you need to be comfortable with it. So STIs are another thing that we're seeing, and I've alluded to this. We're seeing more and more and more in adolescents. Unfortunately, a lot of adolescents treat sex as a very casual thing. Chlamydia and gonorrhea scans are now done at 16 as a regular part of health screening. In fact, with Medicaid, it is in females, it is SOP. And it's one of those things we're dinged on if we don't get a baseline chlamydia screen, which is really interesting. I guess we're looking for, I don't know why they're doing it, unless, of course, chlamydia can be very silent and you can have it for a while and pass it to other people without knowing it. Of course, HPV infections, as we all know, human papillomavirus can cause cervical cancer, genital warts, throat and rectal cancers. And now we have this wonderful vaccine that protects against 9 strains, the most common strains that cause these issues. And we usually start at 11. You can start as early as age 9 given this vaccine, and there has to be, if they're under the age of 15, it's 2 shots, 6 months apart, minimum 6 months apart. But if they go over a year between the first one and the second one, then they end up with 3. So we really encourage those kids between that 6 months and a year, and I look at them and say, okay, if you go beyond a year, if you go a year from now, you're going to have 3. If you come in less than that, it's only 2. And adolescents don't like vaccines. So usually parents are good about getting them in between that 2nd and 3rd year, or that 6 months to 12 months, and they don't have to have the 3rd one. But then sometimes they forget and they end up getting 3. We still have a huge resistance to vaccinating with HPV. I don't know what the deal is. I guess they think their kids are never going to be sexually active, and that they're going to have one partner for life, and that partner's never going to have been with anybody else. And I'd like to think that too, but why wouldn't you protect? We have a vaccine against a female cancer and a virus that causes other STIs. Why wouldn't you not give it to your child? I don't get it. Sometimes I've sat down and talked to them about, it's like, it's not about you. Only you can control what you do, but you can't necessarily control what Mr. or Ms. Wonderful does prior to coming to be with you. And I said, you're just protecting yourself. We've had some parents to refuse, and the kid wants it, so we just look at the kid. It's like, okay, when you turn 18, you don't have to have that parent permission anymore, and we can do your vaccine. And they say, okay. And we've had some to come in on their own because their parents wouldn't let them have it. And then we start their vaccination series for the HPV. But we usually do it in conjunction with their 6th grade physical, because they're getting shots anyway. They're getting their meningitis and their tetanus booster. And so we usually start it then. Again, we can start it as early as 9. Sometimes I'll do it at 10 when they come in to get their tetanus booster. I'll talk to a parent about it. And sometimes I'll wait till the next year when they get their meningitis at their 6th grade. So it's just, but as long as we do it under the age of 15, it's a 2-shot series, minimum 6 months apart. But if they wait till after they're 15, it is a 3-shot series. But I don't get it. but you know, there's a lot of things I don't get. All right. Regardless of admitted sexual history, because you can't trust a child, especially with a parent sitting there to tell you the truth. Suspect an STI if they're having dysuria, pain, and discharge, and they have a negative urinalysis. It should be considered an STI until proven otherwise. So, and I'm gonna, sometimes I'll send the parent out and I'll talk to the child or the patient and talk to us like, and they won't even admit it to me. I said, all right, nothing else is showing up. I'm going to do this, this, and this. Are you okay with that? And they said, yeah, you're not going to find anything. I said, that's fine. I said, but I got to do my due diligence. And I'll bring mom back in. I said, we need, you know, and I'll tell them, I said, we need to tell mom what I'm going to do. And I tell mom, and I tell them it's because I said, she's telling me that there's nothing going on, or he's telling me that there's nothing going on, but I would not be doing right by them if I didn't check this. And so there's been a couple of times that we've had a positive chlamydia, and even the urine pregnancy test. I mean, you've got a kid that's denying that they're sexually active, and then they turn up and have a positive pregnancy test. It's like, oops. So that can be a confrontation there in the room, because if you've got a kid who's saying that they haven't done anything, and you've got a positive pregnancy test, and you've got a parent that's all of a sudden enraged. Also, when you start talking about testing adolescents who are minors for STIs and pregnancy, these are technically considered privileged information, and you can't give that test information to the parent without the patient's permission. Or if I go into a room and the mom and the patient are sitting there, and it's like, I've got test results, is it okay if your parent sits here and listens to these? And they say yes. Then, and if they say no, then I have to ask the parent to leave. So, you know, it gets tough when you're a pediatric provider and you're used to the parent having the say, but when it comes to STIs, it's a whole different ball game. So, and I know that you all have probably dealt with that in other situations. If you haven't dealt with that, trust me, it's going to happen. PID, or pelvic inflammatory disease, is an infection of the upper genital tract, and that's going to be an immediate referral to GYN. Of course, GC and chlamydia are the most frequent cause, and multiple sexual partners and a previous STI are the most common risk factors. It does mimic an acute abdomen with your abdominal pain, dysuria, nausea, vomiting, chills, painful sexual activity, or pain on sex. So you do your workup, your CBC, your SED rate, your CRP, pregnancy, GC, chlamydia, syphilis, UA, ultrasound of the pelvis. So you check out all of this, and if you feel comfortable treating PID, they're going to get Rocephin 250, and they're going to get Doxy, and maybe even Flagyl. So, and they're going to do it for 14 days. If you don't feel comfortable treating this, then you need to see them to a GYN provider. Okay. See, that was nice and quick and down and dirty. If you've got questions about the chapter that I didn't go over, I picked out the most important things that I thought you needed from pediatrics in GYN. And if you have any questions, just shoot them to Dr. Blankenship and we'll take care of them. So I'm going to move and let her do her thing.
Back shortly with our next one.